I am Anna Seawold, and this is Authentic Parenting, a podcast about growing ourselves while raising our children. I'm a psychologist, educator, and parent coach. My mission is to end violence against children. Through my work and through this podcast, I help parents break generational cycles of trauma, reconnect with their authentic selves, and raise emotionally healthy children. Together, we've built a global community of conscious parents who want something different for the next generation. Join us as we create a more peaceful, kind, and compassionate world. Today, Perimenopause Explained: Symptoms, Hormones, and what every woman should know. Perimenopause is a major transition in women's lives, yet many women don't recognize it when it begins. For generations, women were expected to navigate this stage quietly, often without clear information about what was happening in their bodies. So when sleep changes, anxiety appears, or brain fog sets in, many women find themselves wondering, what is happening to me? In this episode, I am joined by Dr. Heather Hirsch, a board-certified internist and one of today's leading voices in women's midlife health. She's the founder and CEO of The Collaborative, a telemedicine practice supporting women through perimenopause and menopause, and the founder of the Heather Hirsch Academy, where she trains clinicians around the world in midlife women's care. After completing Advanced Women's Health Fellowship training at the Cleveland Clinic, she went on to found the Menopause and Midlife Clinic at Brigham and Women's Hospital and served as faculty at Harvard Medical School. Dr. Hirsch is also the best-selling author of Unlock Your Menopause Type and the Perimenopause Survival Guide, which offers practical strategies for understanding symptoms, exploring treatment options, and advocating for your health during these often overlooked years. In our conversation, we talk about what actually happens in the body during perimenopause, why so many women feel confused or dismissed when symptoms appear, and what options exist to help women feel like themselves again. We explore the hormonal shifts that can affect mood, weight, sleep, anxiety, libido, and energy, and why these changes are often mistaken for depression or anxiety disorders. I have also done another informative episode on this topic with another fantastic guest, Tamsen Fadal, and I will link to that conversation in the show notes if you would like to explore this topic further. This is a practical and honest conversation about the life stage that half the population goes through, yet we still rarely talk about openly. Please enjoy, and thank you for listening. Since the book came out, or since you've been writing books and talking about this, is there anything new that you know about this topic? Or maybe some of your ideas or views have changed? I want to start from there. What do you wish you knew before, or maybe you know now?
Yeah, I think it depends if you want a personal angle or a medical angle.
Both. I would love to know both.
Well, I know now how brain fog really feels. So I'm happy to tell you how brain fog really feels. And so I think, I started in learning about this topic when I finished my internal medicine residency. And then I did a fellowship and I was, it was 2014. So I think I was 33 and must have finished when I was 35, and then started building menopause and perimenopause clinics kind of after that. So medically, not much has really changed. I have kind of my own spin on how I like to treat patients. And when it comes to hormone therapy, I talk a lot about hormone stacking, which is like a signature sort of method of mine. And then Personally, I've just started to experience perimenopause about a year and a half ago. So my early 40s. I'm now 43. And it's definitely one thing to write about these symptoms, and it's another to experience them. And it was really funny because even for me, I felt like like I had my own period of being in denial that that's what it was. And again, we can kind of certainly talk about how, when you're doing all these different things, you're at the peak of your career, you've got kids, houses, spouses, pets, all of that. Like, it gets really complicated and confusing to kind of, pull things apart. And we often can't. So I would say, anything you like there, I'm happy to. I am an open book. You can ask me anything, medically or personally.
Personally, I think a lot of people, then number one misconception is people don't know when perimenopause begins, right? We've heard about menopause, but I think perimenopause is a lot newer term. And at least for me, I learned it in my 40s. Let's say I learned it in my 40s. But it's an important phase. And I want you to speak about like early perimenopause, late perimenopause, and what can people expect. I think it would be important to frame the conversation in a way that what's important for women in their 30s to know, what's important in women in their 40s to know. And for us, I am like 51, maybe early 50s. And what's important for partners to know about this topic and how they can understand and better support women.
Yeah. And question wise, for how deep you want me to go for the episode, or just discourse between you and me, or does it not matter?
Yeah, you can just, it doesn't matter. This is the podcast. This is it.
Oh, great. Okay. So conversational and fun. I could talk forever about this topic, and you might want me to come back up for air. But I think starting with some definitions is always a great place, because a lot of times, even on social media, you'll just hear menopause, and maybe the person who's speaking means the entire transition. So it's fun to start just like the definition. Menopause truly is 1 year from no periods, 1 year of no periods, 365 days of no bleeding. And you can say on that day, today is menopause. And then every day after that, you're actually post-menopause. And, you'll hear people say things like, oh, I never really had menopause, or, but again, it's kind of just the way we use these terms. And then perimenopause is all the time leading up to that. And the difference between being premenopausal and perimenopausal is very subtle. And for many women, it's when they first start feeling symptoms. But really, truly, the definition is when those hormones start to change from sort of this rhythmic up and down, if a woman's not on any type of contraception, to more of a subtle decline in those hormone levels and or a volatility in those levels. And then we can break up perimenopause into early and late. So early for some women is often where they will notice periods clustered, or they feel like they're now bleeding all the time. They'll say like, oh, I just had a period 2 weeks ago. I'm still bleeding. I'm bleeding all the time. This is a lot of early perimenopause. And they might also experience insomnia or anxiety because their progesterone can be declining. And they may say things to me like, I've never been a ruminator before. I have a stressful job, or I'm a stay-at-home mom of, 2 kids and 3 stepkids and 6 pets. And now I'm just constantly anxious. And that was never really me. And so what I want women in their early 30s to know is that there is kind of, just like it takes 5 or 7 years for your periods to become regular once you start having periods, in your 30s, you should know that at some point perimenopause is coming, and it could take the same 5 to 7 years for everything to kind of wind down. And so just knowing that is really helpful, because I do think if you can track your periods, this is one of the most helpful things for women who get regular periods. I say that because I don't get regular periods because I have an intrauterine device. So, some women don't get regular periods. So in your 40s is when it's more common that perimenopausal symptoms will occur. And per the CDC, the average age of perimenopause is 47. I think it's a little bit younger than that. And I think if the CDC is only relying on ICD-10 codes as the codes that doctors put in, I don't think they're diagnosing perimenopause correctly. And so early perimenopause is kind of in that next phase where you can have anxiety and insomnia or worsening heavy periods. And then later perimenopause is when those periods really, really space out. And now not only is your progesterone lowering, your estrogen's lowering. And so in later perimenopause, this is when women might have periods that are going every 3 months or 6 months. They're really, really spacing out. And with that lower estrogen can feel symptoms like hot and dry. So it can feel like hot flashes and night sweats and dry hair and dry skin and brain fog and all of those kinds of things.
Oh, so those are the symptoms of low estrogen, what you're describing. I see. So progesterone, so all three hormones basically decrease during perimenopause, testosterone, estrogen, and progesterone.
Yep. Most, progesterone, I should say, let's define fairly steadily and actually is often the first hormone to kind of say goodbye. And then estrogen will kind of be really volatile. Sometimes it will spike way up and then way down and then stay down and then spike up and spike down before finally really calling it a day. And then testosterone also tends to steadily decline. Some women will remain mildly elevated in their testosterone levels. And reasons for that is actually it can be a stress hormone. So your body's feeling stressed because of perimenopause. And so your adrenal glands might actually make some testosterone. And so not all women's testosterones decline, but for the majority of women, their testosterone will kind of start to slowly decline.
So what would be the symptoms of separately, let's say progesterone symptoms, estrogen symptoms, and declining hormone symptoms? This is pretty interesting.
Yeah. So, with low progesterone, this can lead to those symptoms in early perimenopause. For example, because progesterone tends to be the conductor of the uterus, it kind of keeps things, okay, now we build up, now we shed, now we build up, now we shed. As progesterone declines, this is one of the reasons women will start to get more frequent periods or spotting in between periods, which happens in early perimenopause. Progesterone also helps to increase the production of GABA. And this is a very calming neurotransmitter in the brain. And as progesterone is declining, that can be one of the reasons women maybe start ruminating, have more anxiety, or have trouble falling asleep. And then as testosterone declines, there's a lot of things we don't fully know about testosterone. It tends to be very important in our libido, our sex drive. Testosterone may also have important effects on brain function, on, our sort of motivation or get up and go ness, if you want to call it that. And then estrogen, also plays a role in so many things. And we're really talking about the symptoms, not even the underlying physiology of what it does to your brain, your bones, your heart, et cetera. But in terms of symptoms, when estrogen drops, that's kind of when you might start to feel more hot and dry, hot flashes, night sweats. A lot of women experience brain fog. They might experience anhedonia. Instead of anxiety, they might now feel more loss of joy, sadness, or depression. With the loss of estrogen, you can also have some brain fog. Also, this is also probably the hormone most responsible for the stubborn kind of weight gain, or maybe it's not weight gain, it's just bloating, or it's just feeling like your body distribution's changing. So that's what can happen when each of the hormones start to decline.
So this is interesting, right? Like when I first experienced anxiety and some insomnia, those were like, I guess, the early perimenopause. Now that I'm listening to you, it could be easily confused with having an anxiety disorder, having depression, right? And so when you go to a psychiatrist, you may get a prescription for antidepressants. So is this helpful? Is this not helpful? If in that period when you have anxiety, let's say you take anti-anxiety pills, but it's a symptom of perimenopause, like how do we know? Or is it useful to take, let's say, antidepressant, anti-anxiety medication?
This is a great question. And when I see my patients, this inevitably comes up. How do we know if it's perimenopause or is it generalized anxiety disorder? How do we know if it's, and similarly, they might say, how do we know if it's not joint aches and pains from perimenopause, or is it like fibromyalgia, or how do we know what it is? So, in perimenopause, if a woman is still having periods, or if she's not having periods, she's actually still ovulating, sometimes you will tend to see a cyclic pattern. And if you can see a cyclic pattern, that might be one clue that it's more hormonally based than neurologic or neurotransmitters that would make you lead more to mental health dysfunction as the primary reason or etiology. So you can look for things that are cyclic. You can also look to see what makes it better or worse. And again, sometimes is often better during different times of the month. And often, again, if this is, estrogen related, let's say for low mood, we know that actually women in premenopause, they tend to, but not always. I hear women that are actually wired differently, but most women find the first part of their cycle when estrogen is increasing that they feel happy and good. And then the second part of the luteal phase where the estrogen is declining is where they feel the PMS symptoms, which can include the low mood or the irritability. And so if things make it better, like different time of the month or et cetera, that also can point more towards hormonally mediated things that can make hormonally mediated things better. Also include like changing your environment, particularly for the second part of your cycle, your luteal phase, if anyone's really in tune with those things. Whereas generalized anxiety and depression tend to be pretty stable most of the time, and they don't tend to have like a cyclic response to them. Now, then ultimately, Anna, if we're not really sure, you can try a hormone therapy. Now, in a way, sometimes when I talk with my patients, I'll say hormone therapy can be hopefully therapeutic, but oftentimes also diagnostic. So what I mean by that is, sometimes the only way to know, is it hormonal or is it maybe more neurotransmitter if we're just talking about mood dysfunction versus perimenopause. If you try hormone therapy, it will either help or it won't. And if it does, then it's very helpful to either rule it in or rule it out as, what is in fact what is actually causing it. And then like, which one do you kind of choose first? And I write about this in my book. I think it's probably fair to say that I'm a little biased, that I think hormones play a big role. And I also think it's fair to say that, I, over the years, have had patients come to me and they'll say, look, I've had anxiety or depression in college. I've had it before in periods of my life. This feels different. They'll say like, this feels different. And I'll go through, again, as long as there's, no major red flags and it's still safe, there's no concerns for harming themselves or things like that. There's of course things that you don't want to check out for. But with shared decision making, they'll prefer to start hormone therapy first. That might be also selection bias. That might be why they come and see me. And I would say more often than not, they really start to feel better. And then I have some patients who do feel like, maybe other things got better, but the mood. So we do add an antidepressant. And actually, we know estrogen and an antidepressant can work really nicely together. They can have a very synergistic effect. And so, or if it doesn't make any difference at all, then they know maybe it's time for another way to treat that. So that's just kind of some of the ways in which with patients, we work through, is it this or is it that?
Okay, so you answered my follow-up question, which is, can you take anti-depression or anti-anxiety medication and hormones, estrogen? And you said yes. So I have one crazy question. This came from my community. Last time we talked about perimenopause in our support group, and a question came in, and I'm going to ask you since you are an expert. So obviously the people who listen to this podcast, most of them have kids, right? They're parents. But is it true that if you're someone who didn't give birth to children, your perimenopause symptoms are going to be worse? You're going to have a worse time. You're going to have worse symptoms as opposed to someone who had one or two kids. Or is that the myth?
That's a myth. That is, which is, good to know. That's a myth. A lot of the symptoms of perimenopause, we don't know why some women will get and some women won't. I see so many interesting things. For example, I would see some women experience really terrible perimenopause and then an easy menopause. It's another myth is that if perimenopause is terrible, menopause would be terrible. And that one, again, myth. Or I will see someone who was fine up until their period stopped, maybe even 1 or 2 years into menopause, and boom, all of a sudden the symptoms really start. We also don't have any way to predict who's going to get what symptom set. And the way I kind of write both of my books, so the Perimenopause Survival Guide and Unlock Your Menopause Type, is in the middle part of the book. I kind of break it down by symptom set, and it's meant to be a way to personalize your journey. It's meant to be a way to kind of read certain chapters that may apply to you more, but we don't have a way to predict who's going to have mostly mental health changes, and who's going to have just the, vaginal dysfunction, genitourinary syndrome of menopause main symptoms, who's going to have no symptoms, because about 10 to 15% of women are pretty asymptomatic through the entire transition. We do not have a good way to know. And since we're myth busting, another myth is that if you work out and you're healthy and you eat clean and you don't drink, that perimenopause and menopause will be a breeze. And you'd think, well, yes, nope. I know so many health coaches and nutritionists and social workers and folks who take really great care of themselves, which I'm not saying do not do those things, but they don't seem to, you can't sometimes outfox your physiology. Your physiology is going to really, really bother you. Doesn't matter if you have children, have not had children, had a late period, an early menarche. Doesn't matter. And a lot of us, there's a myth too that what happened to your mom will happen to you. Some women, that is true. Some women, it is not. And we just don't know how to predict who that happens to. So thank you for giving me that little chance to do some mything.
Yeah, well, you answered all my questions around those things. Because yes, so it's basically like a spell. Some people get it, some people don't. I know my friend is same age as me, and I feel really bad when we get together. She shares her experience, and her experience is really horrific. The bleeding, the non-bleeding, the stopping, the coming back, the body changes. She hates her body. She's buying different clothing, the sleep issues. She can't get out of the house, the low mood, the depression, all of those things that you're describing. Everything is hard for this person. And when we meet, I am not in the same boat. And I'm like, am I lucky? Is it because I don't drink alcohol? Is it because I'm exercising? Is it like I question those things, but so there's no way of knowing. And like you said, maybe my menopause will be harder than this period. I don't know. But so one never knows. Basically, it's a very unknown thing.
Exactly. But that story made me think about the fact that I hope that your friend is getting treatment and support, because what happens.
No, she's not. And so I'm gonna mention it to her. I feel like after listening to you and reading your book, I feel like maybe she should talk to her doctor about hormone therapy, because if it's debilitating you to the degree that you can't parent, you can't live your life, and you have so like low self-image and you hate your body, and from externally it doesn't look like that, but I think the internal sense about herself and her life and body, and maybe she's a candidate for hormone therapy.
I mean, I would say most likely, based on a minute or two I heard, because truthfully, and this is a really important point, and it wraps into so many things that you just said, which is that when you're experiencing symptoms more often than not, or they're affecting your quality of life, which both it sounds like is happening, honestly, not only is treatment a safe and effective option, but delaying treatment, I think, is going to only derail the health even further. Because what I see happen to a lot of women historically now, and let's go back maybe 10, 15 years, we were told, oh, you're just anxious, have a glass of wine, oh, maybe you need some Xanax and some Ambien. And, then what happens? This begins a trail of derailing your health, because we're not treating the underlying cause, and we're numbing you. And, not that there's anything particularly wrong with, those treatments per se, but like in this context of what was really happening with perimenopause, the best and the safest option is menopausal hormone therapy, which actually can really help turn people's health around so much. I think the best thing you can do as a mom in 45 to 55 is take care of your health. Because if you don't, and this is the crucial time where this is the most important transition, this perimenopause to menopause, because one of two things will happen. Either it will derail your health, because most women suffer through. Most women were told hormone therapy is bad. Most women were told there's nothing that could be done. Or most doctors just told them, oh, you should just drink a glass of wine, just relax, sweetie. And I can't even believe I even said that in a sarcastic way because it felt horrible to say even in a joking way. But I think that's what happened to a lot of women historically. And what happens, again, those things don't get any better. And you're band-aiding them with a really bad band-aid. And then we develop cardiovascular disease, diabetes, brain fog, lose self-confidence, quit our jobs, quit the workforce, and we become socially isolated. Okay. I know I'm making it a little extreme, but I'm making a point here.
Wow. This sounds scary, really.
And
so this is basically like it can be the onset of so many other diseases like Alzheimer's and dementia and diabetes.
It's not that it happens overnight, but it is no coincidence to me that as our hormones decline and drop, that our chronic diseases develop. Most women, let's say in that, maybe early 45 to 50, outside of obstetrics, the majority of women, hopefully, don't really have to see a doctor very much. This is the time when the healthcare utilization really goes up. Why? Well, someone's saying, like, we're going to use your friend as an example. Okay, well, then you need mental health and you need to see the GI and you need to get your thyroid checked and you need to go to the gym and maybe you need to see a nutritionist and maybe you need to get on an antidepressant and all these things. All of a sudden she's like going to see 8 different doctors. They're treating her 8 different ways. What if it was just perimenopause? And if we gave her a little bit of estrogen, a little bit of progesterone back, boom, she feels like herself. She goes to the gym. She's being out with her friends. She's getting that promotion at her job, or she's volunteering more at a church, whatever it might be. It really changed the trajectory of your life that much. And again, it doesn't happen overnight. But again, the days are long, the years are short. So all of a sudden you wake up and you don't recognize yourself anymore. And so there's lots of barriers to that, though. And I can say this from a seat of at 2025, we now have, we know more about the safety of menopausal hormone therapy. It's becoming a little bit less taboo to talk about perimenopause and menopause. We've got lots of people talking about it, writing books and on social media. But we still have a long way to go because it's not your friends. This is an entire system failure from the medical community. It's not so much failure on your friend's part. However, luckily she has you. And, we need to spread the word amongst each other that perimenopausal or menopausal symptoms, they can be so severe, and not treating them, not that there's one right way or one wrong way, but not treating them will derail your health and could possibly really, lead to more chronic diseases. And this is the time, they say, start investing in your 20s, start investing when you're young, because the earlier you invest, between 45 and 55 is where you start investing in your generational health so that you can be, 82 and get on the floor with your grandkids, or be 82 and go to the grocery store by yourself and not rely on your children to take care of you. This is the time where we build generational health. And it's really because of perimenopause and menopause that this time becomes so crucial.
And so what are the risks? Do they have long-term studies? Did studies on this hormone treatment? Do they follow women and see, do they develop chronic diseases later, much later, or never? Like correlation with that. Is there data available about that?
There's actually some fairly good data, and not as much as we would like and not as recent as we would like. And that actually has to do with the stigma of hormone therapy. But here's what we do know, that if women start estrogen, we have the most data for Premarin, which comes from horses, but if they start estrogen within 10 years of menopause, and we're talking about perimenopause here, so you're even before the starting line. But the idea is if you get estrogen and you start it before 10 years, that actually the Women's Health Initiative showed that women had less heart disease, the leading cause of death in women. They lived longer, on average 3.2 years longer. There is no other device, no other medication that has been shown to increase women's health span besides for estrogen, even though every tech bro in the world is looking for it. Only thing that's been proven to help increase lifespan and health span in women is estrogen. So reductions in heart disease, reductions in death from all causes, which is your longevity, reductions in osteoporosis, reductions in diabetes. And it's always funny whenever I say this, because I'm pretty sure that a person on the other line is like, how is that possible? Like they told us this stuff was so bad for us for so long. And, that's really why so many of us who are, physicians or in different specialties, I learned about this in my fellowship training at Cleveland Clinic in 2014 and I finished in 2016. And once I learned it, I just could not stop screaming it from the rooftops because, I feel as though women deserve the truth of the matter. And it really got complicated because of fears of breast cancer, which have now been debunked. It really depends on the type of hormone therapy that you use. And we use mostly progesterone as the progesterone component or prometrium. And, really these fears got so blown out of proportion and crazy and biases developed and extinction of training happened. And, this is really where we are now that I can sit here and say, we have data that shows that this is so good for women. If you want to live longer for your kids, you might want to consider have a discussion with a clinician about your use of menopausal hormone therapy. I can say that, and some finding a doctor is still a barrier, and it's not FDA approved for preventing those diseases, even though the data shows that, but it is FDA approved for hot flashes, night sweats, vaginal dryness, and preventing osteoporosis, which most women have. Most of those or some of those things anyways.
So it used to be called hormone replacement therapy, right? I remember that term reading and hearing. When you say hormone therapy, is it both? You receive both? I want you to speak a little bit about that because you said you can also stagger. So I have no idea what hormone therapy is. So when you go on it, are you on it forever? How early can you go on it? Do you, like you said, you don't have to wait until it's too late. How late is too late? How early is too early? And illuminate us a little bit.
Sure. I think starting with what is hormone therapy is a great idea. So the term, I think if you want to be at a dinner party and use, be the smartest girl in the room, menopausal hormone therapy or MHT is really the preferred term. Although most people, I remember when I was working with companies, they'll say, well, the most Google term is HRT. So we've got to put HRT even there, even though a lot of times we're talking about menopausal hormone therapy or MHT. And that is typically implies the use of an estrogen, a postmenopausal dose of an estrogen plus progesterone if you have a uterus. If you don't have a uterus, you don't need to take progesterone. Its main role is to protect your uterus from a very small risk of cancer without progesterone while taking an estrogen. And then plus or minus testosterone as kind of the trifecta. Now, menopausal hormone therapy, I have a patient who's on progesterone and testosterone. She doesn't take any estrogen. Gives her too much breast tenderness. We tried it and tried it and tried it. And ultimately, the progesterone helps with her sleep. The testosterone helps with her libido and her drive. And we might retry estrogen again. We also have vaginal estrogens, which just treat the vagina. So I have a patient on vaginal estrogen only, and that's her hormone therapy regimen or her menopausal hormone therapy regimen. And so it can kind of be different things. The only caveat is if you do have a uterus and you are on estrogen, you must be on progesterone. Now, hormone replacement therapy, actually in the textbook, typically means if you need to start hormone therapy because you've entered menopause before age 45. And that's what R actually stands for physiologic replacement. So younger women really should, if you younger being under 45, if menopause, like the complete definition, no periods in a year, and whether that was surgically induced and you had your ovaries taken out, or the ovaries have said, we're not working, it's been a year. The idea is actually you might need higher doses of hormone therapy because we're physiologically replacing it. That's actually where the R comes from, HRT. And same thing, HRT means an estrogen plus or minus a progesterone, but must be a plus if you have a uterus, plus or minus testosterone. And so that's kind of the main definitions of HRT versus MHT and when and why you would start it. And the fun thing is really, and probably too many different scenarios in this show, but, for a lot of women, we always say one size does not fit all, one size does not fit all. What I like to do, this kind of stacking that I talked to you about, is when I see a patient, like, your friend really is getting all the attention here on our show today, but it's the perfect example of really tell her what I see every single day and what women really are experiencing. It's not, it's not unfortunately rare, but I might say, okay, I like to start one hormone at a time. Why? Because I learned that if I start you on estrogen, progesterone, testosterone, you come back, gosh, my pinky really hurts. I don't know which one. It was hurting your pinky, probably not the whole thing. And people always say to me, I tried hormone therapy and it didn't work. And I always say, I bet you it was one part of your hormone therapy, not the whole thing. So I've learned this kind of signature method, and I teach clinicians this, that I do this thing called hormone stacking. And I usually try to take your worst symptom. Let's say for your friend, what's her symptom? What do you think would she might guess as to what her most bothersome, her two most bothersome symptoms?
Oh, I think the mood, from what I know, like the low mood, the anxiety, the rumination, the not sleeping, like if we take that, and the body image, the midsection fat. I mean, she's beautiful,
Yeah.
but she feels
Of
very low on
course.
herself and like just very
Yeah.
low, negative, and that's and no energy to get up and do things and things of this nature. I think that's the worst one.
I got you. So in my book, in my second part of my book, I probably put her in the feeling unrecognizable to yourself, just kind of like from head to toe. She's like,
Yeah.
who is this girl when I look in the mirror? So in that symptom set, most of those patients I feel like do well on all three. I can hear like there's probably some low progesterone because the in not sleeping, maybe the body changes, and the low mood is the estrogen, sort of the like fatigue or the get up and go is low testosterone. So in that case, we kind of want to get rolling. So maybe I would start her on progesterone just to see this help you with sleep. Let's get some sleep. Sometimes just like better sleep, we're like 15, 20, 30% better. Okay. Then we may add estrogen. Oh gosh, great. Now you're feeling like a little bit more like you, the confidence is coming back, all of those things. Great. And then maybe we add the testosterone. And of course, I would talk with my patients and they would kind of walk through, what they kind of feel like. We do some shared decision making. Another example is, I have many patients, they'll come in perimenopause and say, this insomnia, I cannot fall asleep. And so, now that you've listened to this show, hopefully, that's probably more progesterone. And so we'll start progesterone and I'll have them come back in 4 weeks. And then if that was, worked well, or do we need to tweak that? Does that need to change dose, or do we need to add something else, a different hormone? And so you can kind of see, I had a patient I just saw, she's actually now, well, she's a menopausal patient. She's 3 years out of menopause and the hot flashes are the worst. And so we're going to start her on estrogen, and then, she's going to come back in 4 weeks, and then we're going to add the progesterone because she does have her uterus, and it's okay to do them a little staggered. And, you can really see it very much. I really try to tailor this. What stage are you in? What symptoms are bothering you the most? And then there's all sorts of little paths people will take depending on if one hormone worked badly for them, in which case we try a different dose or a different formulation or a different route, or so many different things that we can do, Anna, so that we really individualize and tailor hormone therapy for you. And so that's really why I write the book kind of in these symptom sets. So you can kind of start and get some relief and then learn more. And that's exactly what I like to do in my clinic. Get you some wins, get you some relief, and then keep working at it.
Oh, so it's really customizable.
It really, really is. And I think that there's a lot of experiential learning. And I think, having been so lucky to have been able to treat so many women and speak with so many women who've trusted me and help them along their journeys, I think that's been so crucial in helping me really learn how over the years to really customize. And now another thing I do, I treat patients, but I also train clinicians. And so I have this incredible course on my website, Heather Hirsch Academy. And that's because we need more clinicians. And experiential learning is difficult because it takes a lot of time, just to see that many women. But the way I teach, I really try to throw in, these little caveats. So if I can do anything to really help increase their confidence in individualizing while they're just starting, I think that can help because I always say what works for you or your friend is probably going to be different than what works for you ultimately. And so clinicians really need to know some level of customization, maybe not the OCD type that I have, but some level of customization.
I see, I see. And do more and more women are seeking hormone therapy these days? And what are their fears? Like, I'm really nervous to put things in my body, for example, like artificially. I have to be honest, like, I would feel, I don't know how I feel. I'm sure it helps. And I'm not arguing that, and your life can be better And I'm not judgmental of that, but as an individual, like if I get a headache, I don't even take medication, let alone to put a hormone. I was never on contraceptives. I've never done anything hormonal. And so I'm always nervous. So I'm sure there are people like me. Why do we have fears? And what would you say to us, people like me? And I'm not scared of, I guess I'm not scared of like developing breast cancer or anything like that. That's not my fear. My fear is like, I don't know, like this is my body. This is what nature intended. It's declining. So what? Let it decline. And I'm going to die one day. It's fine. Like, why do I want to like put artificial things and make myself, yeah, I'm a little like not okay with that for myself. So what are people's fears, women's fears? And is this like more common now, the hormone therapy?
I first off want to say I think how you feel is totally valid. And a lot of women will feel like that. And, I think it's also just a great place, just to say, I really, really, really strongly feel like there's no one right way or wrong way. There really, really isn't. And one of the reasons I do talk about hormone therapy so much is really just to break down some of the myths and misconceptions. And there may be some women who don't want to take it because they are still afraid of breast cancer. They think they can't take it because let's say they're smokers or they've had a family history of a blood clot or something. And there's so many myths and misconceptions. And had they just known that, they would have felt a lot more comfortable. And so I think, Anna, that you make a great point. It should be shared decision making and it should really be up to you. And I really, really firmly believe that. And, there's so many lifestyle things, there's supplements, there's non-hormonal medications, assuming if someone like you who doesn't like Advil, you don't want the non-hormonals either.
My OB suggested I had heavy bleeding and I was anemic. And she said, in a passing, by the way, this is what the doctors that have like a few minutes with you. And this is one of the best doctors that I go to who is pro women, like she's very gentle and loving. And right, this is like that type of a doctor. In a passing, she just said, well, there is non-hormonal treatments. And I'm like, maybe explain, maybe like, let me ask you a question. Like, what is it? What did you say? So, yeah, I want you to say a few words about like non-hormonal treatments. Like, I would not even put an IUD. If that's the non-hormonal treatment, I don't want that.
I think a couple things, and then I'll definitely talk about the non-hormonal.
Am I weird? No. Maybe I'm weird. Yeah.
No, not at all. And not at all. And I mean that so honestly. So I'll have people like you and they'll come to my office and they'll say, but look, I am also really suffering. So there may get to a point where a person who is very much kind of, let's say, wants to avoid pharmaceuticals or something like that might get to their breaking point. And that's really where I also bring in the like, look, suffering is going to derail your health. It really, really is. And it might not stop. And, is there other reasons why we might want to help, and they might say, yes, I want to be around for my kids. I don't want to have a heart attack. I don't want to not get any sleep that I'm, just a shell of my former self. It's not helping anybody. In fact, some people, even moms, they might not even come to my office until they're like, I snapped at my children so much. They've been hiding from me for a week and I need help. Something else might push them. So anyways, and that is all true. There is no medal if you're suffering. And another thing I say to my patients who are very trepidatious about pharmaceuticals is I'd say, Anna, like, again, I don't think you might be kind of almost need to be in a position where you're like, I feel really crummy. Like I'm at the point where I'm considering this. And I'll say, let's try it for 2 weeks. Nothing will happen.
Oh, so you can try for 2 weeks and get off of it?
Yeah, of course. It's not like this is yours forever and now you're stuck. No way. We can talk about how long too, but I'll say, let's just do a trial. And let's use that body feedback and that biofeedback and see. And so a lot of my patients will do that and they come back and they're like, oh my God, I'm a million times better. And then they're kind of more like, okay, but sometimes it's just taking the pressure off of like, well, now we're going on hormone therapy. I tell my patients all the time, we can do a trial of a very low dose of hormone therapy. And truthfully, since a lot of our hormone therapy is plant-based, if I was a non-pharmaceutical, if I was like, I'm just using you as an example, I think the most, I would say, the most natural of all the options, even the non-hormonals, would be a low dose estrogen patch. It's plant-based and it's estradiol. And really, it's the low hormone that's causing the symptoms. So replace the hormones, right? To me, it actually sounds more natural than the non-hormonal options. So that's sometimes what I say to my patients. And then wrapped in there too is I think, there is a lot of deep-seated, like, this is natural and this is, so childbirth is natural, death is natural, but we still have medications to help support people through them if those transitions are particularly difficult. And suffering through a bad childbirth, right, delivery without medications or doctors could result in a lot of unnecessary morbidity and mortality. So at the same time, those are kind of sometimes the ways I help people if they kind of feel like they've come to me and they're like, help me through this. And that's how. The other thing too is even if you don't have symptoms, Anna, we know that the female body completely changes. The blood, the bones density, the bones get thinner, your heart changes, your brain changes. And so it's also just important, I think, and to just have the knowledge, not that still means there's one right answer or not. Now, non-hormonally, we've got some good medications. So there's FDA-approved medications to target hot flashes and sleep. And these medications target the hypothalamus. And so this part of the brain starts to kind of be irritated that there's no estrogen anymore. Because like, why does estrogen control our core body temperature? Nobody knows. That's how God made us. And so if we apply these medications, they can kind of stop the signaling from the hypothalamus, and that can help to stop hot flashes and night sweats. We've got non-hormonal medications. Of course, for mood, your typical selective serotonin reuptake inhibitors or dopamine agonists that give you those happy neurotransmitters in your brain. We have those medications if that's your main symptom. We have medications for low libido that are not hormonal, not testosterone. We've got a medication called Addie or flibanserine, and it really actually works by increasing dopamine, the reward hormone in your brain. And there's others as well. And so if we're looking at non-hormonals, there's many, many off-label. If we're looking at non-hormonals, we target your symptoms, same as we would maybe using hormone therapy, and then we go backwards. What symptom is bothering you the most? What symptom, if we could resolve, would really help you feel like yourself, help you in your daily life? And we target that with the non-hormonals.
But so not all OBs, not all doctors are qualified, or they don't believe, or they don't use hormone therapy? I didn't quite understand that part.
Yeah. The main problem is I tend to think about it more in terms of education. And the education has really, I take the onus off the clinicians and place it on the educational system of, whether it's medical school training, nurse practitioner school, PA, physician assistant school, pharmacy school. Hormones have just literally become extinct from the conversation. And also what's really problematic is that as I was talking about that generational health, building that now, as I was talking about how our hormones decline is when chronic diseases develop, for so long, and probably still to this day, because I don't know what medical schools learn, menopause is just this siloed little thing. It's kind of like, oh yeah, and this is the definition. It's not really thought of as a huge part of the transition and woven into women's chronic diseases, and it really, really should be. And so no one's teaching about the importance of menopause and how the bebody changes. No one's teaching hormone therapy because we learned that 25 years ago it was kryptonite, and so training became extinct. And when training becomes extinct, that's literally what happens. Now, those clinicians 20 years ago who went through med school are now the ones teaching residents, and they've never seen anyone prescribe hormone therapy, and they were taught it was bad. And so you just have this funneling, this doubling down of, not really understanding the nuances of prescribing hormone therapy. Now, it's really, I always say, like, it's really not rocket science. Like, taking a rocket to the moon sounds a lot harder than prescribing estrogen, progesterone, and testosterone. And yes, there are nuances. And yes, I've talked about them on our recording today. But any doctor can prescribe hormone therapy, just like any doctor can prescribe any antibiotics. Sometimes the infectious disease doctors are the best, but any doctor can get you started on antibiotics. Any doctor can prescribe antidepressants, even though maybe the psychiatrists know them the best, but really any doctor can. And this is the same with hormone therapy. Any doctor can prescribe hormone therapy. And I now have doctors in my class who are doctors. They're trained to be emergency room clinicians, and they want to learn how to prescribe hormone therapy. It's not just the gynecologist, it's the internal medicine, family medicine. I've even seen psychiatrists want to take my class because they're thinking to themselves, I might not want to be the best psychiatrist at hormone therapy, but even starting some of my patients on this and sending them to a specialist might be very, very helpful. And so it's really, again, it's, we always say hormone therapy isn't Santa Claus. You don't believe in it or not believe in it. It's a FDA approved, safe and effective medication that most women are good candidates for, but it's the experience of learning and getting the consulting and hearing it from your attendings or your doctors that are mentoring you, that with that extinction is why we're in this place now where it seems like, you got to try hard to find the right doctor. But I think, my philosophy is treat and train in technology. But I love training clinicians. I've now trained over 2,500, if not 3,000 clinicians on how to prescribe FDA approved, safe and effective menopausal hormone therapy. And the more we can just train, the more women we can treat.
And when a woman goes on a hormone treatment therapy, you said that, it can be experimental, like 2 weeks. How soon can you see symptom relief when you start treatment?
I kind of have this saying, I say 2 days, 2 weeks, 2 months. And so again, as every woman kind of has a different regimen, we'll kind of see slightly different responses. The majority of women by about 2 weeks will either notice something. Some women, they will tell me, and I would say it's, but they'll say, Dr. Hirsch, I put that patch on and the next day I was a new person. I swear. Is that true? And I'm like, I bet it. I hear it a lot. And then for some women, it can take slower. It can take up to 2 months, or we have to do a lot of tweaks. Maybe they're very sensitive, maybe, etc. So I would say on average by 2 weeks, most women notice. They either kind of get that gut feeling like this is going to be helpful for me, or maybe, gosh, this one symptom, it's helping. I didn't know my hair could be so beautiful, but that ringing in my ear, it's not going anywhere. And so, I say by 2 weeks, we start to get some clues.
And is it true that men also take estrogen these days just to be the younger, youthful, healthier? I've heard about this. Is this a myth or is this true?
Kind of. I think it's funny. I was going to say, I know that men have been more interested in.
I'm sure they pair it with like extra testosterone. I don't know, but I've heard, and I'm not sure if it's true or real or gossip.
Yeah, I definitely hear, a lot about, men also, kind of along the same lines, like, you know, um, could it be my hormones? And certainly I hear a lot about men starting testosterone. But I guess since I don't see men as patients, I kind of don't know terribly much. I only know what my patients tell me about their partners, but that's really it.
And this is the last thing. So thank you so much. Number one, this is like very educational. I'm learning a lot, and you convinced me about not being so fearful of. So if I have worse symptoms, since if it's experimental and you can go on and get off, like if I am debilitated at some point, I may not be as scared to try. Number one, I'm going to recommend my friend definitely. I think she definitely needs it. I am okay at this point in my life. I am fine. I'm not denying, it's not affecting my quality of life. Let's just say it. What was I going to say? There was an article in the New York Times recently about women getting testosterone. Did you read that article? And it was so shocking, first of all, to see how many women, reaching for this treatment and what they were reporting, what the results are, what the risks and benefits are. I guess it was very accepted, right, for men to get testosterone treatments, but women were never, about women's hormone treatment. It's like only now it's becoming more common and acceptable and people talk about it. Yeah.
Yes. And, it's really, I definitely think I see some geographical differences. It's really, really fascinating. And this is just what Heather Hirsch sees. So, someone else definitely could say something different. I think in general, hormone therapy has been deemed socially acceptable, medically acceptable. It should be deemed medically acceptable everywhere. But again, that's something the medical community really has to work on. And as a clinician myself, that's something I take the onus on. Socially acceptable, I think, meaning or culturally acceptable, or sort of just like we even talked a little bit about, like, I have these feelings about my health and medications. And so I think, I mean, kind of like that, certainly blue zones, I do think seem to maybe be more receptive to hormone therapy. And these are pure generalization. And then there are definitely geographical zones where those women are like, if this is going to keep me younger and prettier, shoot me right up. I don't care what is in it. And so I think when I think about the New York Times article, I think a lot about geographical differences and kind of the stressors or the pressures or what, beauty standards, so many different things, or sexual standards, or, unrealistic expectations placed on women and certain geographical reasons where women's like, I must keep up, and I'll do anything to do that. And again, very, very broad generalizations here. So I really just mean this all to say, I think that, that I see the whole spectrum from Anna, who says like, I don't even want to take Advil, to, I must be young, beautiful, and, give me whatever I need. And I don't think that one is right, neither is right or wrong. It's just really interesting that there is such a broad spectrum. And, you might read that article and be like, what? This is crazy.
I was horrified. You know what horrified me the most was like, I mean, I can get behind some of the things. They were like, my sex drive is high. I just want to have sex like a man all the time. That's all I'm thinking about. They saw changes in their voice, hair growth, and all of those. But what horrified me was that they didn't want to be a mother, a parent anymore, and nurture. The nurturing aspect of the quality of that motherly quality was diminishing. They were just becoming very basically sex obsessed. And I was like, wow, if like moms don't want to take care of their children, like who's going to take care of their children if they want to get on testosterone? And they were like, I'm starting a business, I'm an entrepreneur, this gave me this boost to do this. Okay, but who's going to take care of our kids? Like it was so like scary to read that part, honestly.
Yeah, and those are definitely clear signs.
Yeah,
that these are dangerously high levels of
extreme.
Yeah, these are extreme. This is so extreme. And thank you for pointing that out, because really the goal of hormone therapy is that you feel 80% better to your baseline of the best version of you. And these kinds of things where people are feeling totally different than they ever did, or different baselines, or these are clear signs that there's super therapeutic dosing going on here. And, around, my practice is called the collaborative, and, we treat patients very, very safely and in safe doses. So I'm glad we did bring that up, because those would be signs that your doses are not correct and not good for long-term use. And these sort of expectations are, I could talk about this for a long time, but they come from actually unapproved medications, usually injections and pellets, that really rose in popularity because there was an extinction of doctors that would prescribe safe and effective FDA-approved hormone therapy. And they give hormone therapy an unsafe and a bad name in many ways. And so, I think it all brings us back down around to there should be shared decision making. It should be safe and effective, FDA approved, and you can go low and slow. And any of these medications should be very, very easily reversible. And if we don't train clinicians how to prescribe safe and effective medications, we're going to get these two extremes where no one's given hormone therapy like your friend who clearly would be of benefit of a consult, or people are going to be doing crazy back alley things. And both of those are not good. And so I am so glad to be here and to talk about, what are the ways in which we can help women have better understanding of their body through this transition, why I think it's so important to build generational health, and your whole slew of options, whether that's lifestyle supplements, non-hormonals, or safe and effective low-dose hormone therapy.
Yeah. Well, thank you so much for doing the work that you're doing, writing the books, your advocacy. You're also a practicing doctor, I mean, which is impressive. What state are you in? Do you see individual people?
Yes. So let me tell you about my practice is called The Collaborative. You can find us at jointhecollaborative.com. Actually, we're membership based, and I work with 12 other clinicians, and altogether we have about all 50 states. I'm licensed in many states, although I'm pretty full at the moment with my patients that I've had for many years. But we are accepting new patients, and we're a great group of clinicians. We all work really closely together. We also have a community, and we do mental health, and we talk about fitness, and we talk about nutrition. So we really like to be holistic, because we know that HRT is one component, but you really have to do the whole biopsychosocial and the whole really holistically. You have to think about what we're eating, how we're moving, and we just really, really care about helping patients feel really, really supported from head to toe. And so that's called the collaborative.
And I will have links and everything to all the resources, your website, books, and everything else. And you create YouTube videos. You're very, very modern. You're very trendy. You have you do it all: podcast, YouTube, and last night I fell asleep by watching a YouTube video of yours.
Oh goodness! I wonder where I was because I was going to say we kind of have the pandemic to thank for that because
no, it was pretty educational, I mean, yeah, you are very passionate. That clearly shows. And I love that. Yeah. Thank you so much.
Thank you.
I learned so much.
Thank you. Yeah. I know. And I was watching your YouTube channel as well. And, it's great because I think I was going to kind of say, and I guess I'm being pretty blunt, there's a lot of garbage out there that you can watch. And, if you can find someone who you can keep their pace and they're entertaining and they're teaching you something that you really want to learn, you're confused about, the education creator economy, I think is a very fun place to be. So I'm glad you get to be there as well.
Thank you so much, Heather. I really enjoyed this time. Wishing you lots of luck in your future endeavors. Yeah.
Well, thank you so much. Thank you for letting me talk. And I hope your community likes this episode.
That concludes today's conversation, my dear listener, and I hope you found this episode helpful and inspiring. Be sure to hit that follow button so you don't miss future episodes, and take a moment to leave a rating and review. It really helps others find the show. I would love to hear your thoughts and takeaways. Join the conversation in the Authentic Parenting Facebook group or visit the contact page at authenticparenting.com/contact to get in touch. Authentic Parenting is an ad-free show, and your donations is what makes this podcast possible. Support the show by visiting authenticparenting.com/support or becoming a patron at patreon.com. Your contributions make it possible for me to continue bringing you weekly episodes. And as always, connect to the present moment, to yourself and your children. Until next week, I am Anna Seewald. Thank you so much for listening. This episode was edited and produced by Ami Noor. If you need expert support to bring your dream podcast to life, from editing to full production, Ami Noor can help make it happen. You'll find his link in the show notes.